Welcome. I'm Carol Jenkins, Executive Director of Cystic Fibrosis Research Incorporated, or CFRI. This CF Discovery Series was developed in collaboration with Camille Wasowich, who is nurse practitioner at the Stanford CF Adult Clinic. It was designed to make vital CF information accessible to the CF community. Before beginning, I'd like to note that no information presented tonight is intended for a patient's diagnosis or treatment. As always, we urge you to work together with your healthcare team for best medical treatment. Tonight we're looking forward to our presentation, CF Airway Clearance on the Go. Thanks to Genentech and Gilead Sciences for supporting this important evening. Their support pays for the venue, the refreshments, and the studio we've constructed here, and all other costs associated with the program. Tim Cochran is here tonight from Gilead, and we're so glad to have you. Thank you for joining us. Please stop by and say hello. Tonight's program is being produced by your CFRI Live team. Eric Martin, Scott Wakefield, David Suhu, and Joanne Davis, who is tracking questions from our online participants. Mary Convento is coordinating the registration and handling our cross-infection support tonight. We are live at the Crowne Plaza Cabana Hotel in Palo Alto, and I encourage you all to ask questions, whether you're here in the audience or part of our online community. Hello especially to those of you who are in the hospital. We're so glad you could join us. And finally, thanks again to our volunteers tonight who help us with their support of our cross-infection guidelines. Our speaker is Kristen Shelton, CF Respiratory Therapy Coordinator at Lucile Packard Children's Hospital at Stanford. Kristen graduated from the Foothill College Respiratory Therapy Program in 1981. She received a bachelor's degree in human development from CSUEB in 2009. Kristen has been a respiratory therapist for 30 years. She's been at Packard Children's Hospital at Stanford for 28 years and has worked with CF patients in some capacity the entire time. For the past 10 years, Kristen has worked exclusively with the outpatient CF clinic. She notes that she's proud to volunteer for CFRI as a board member, and she has attended 15 or more CFRI family education conferences. She also volunteers for the Delta Pet Partners, visiting people in nursing homes and hospitals with her golden retriever, Mac. Please help me welcome Kristen Shelton.
Thank you, Carol, and thank you to everyone at CFRI for inviting me tonight. I would like to make this talk as interactive as possible, so please, if you have any questions, interrupt me and let's discuss it while we're on the subject, because it's a lot easier for you to remember that way. I encourage any questions. I also encourage you to go back to your CF center and talk to your respiratory therapists, because they have a lot of knowledge that they are happy to share with you about airway clearance, and they can get you going in the right direction. I want to start out by talking about some of the technology-dependent airway clearance techniques. The reason I'm starting here is because these are the really tried and true methods that we recommend to the patients that we see in the clinic. These do not require a lot of special techniques or effort. It's a lot easier for families to learn these techniques, and that's why we stick with them. Chest physiotherapy has been something that I've taught for the last 30 years, and it is kind of the gold standard of airway clearance in CF. A lot of families have been moving towards the vest. It definitely offers a lot more independence, and it's also very foolproof. The patients find that it works well no matter what they do. The intrapulmonary percussive ventilator, or IPV, is a pretty specific piece of equipment that is available for home use and hospital use. Vibratory PEP is a very portable piece of equipment that is relatively inexpensive. And positive expiratory pressure is also relatively inexpensive and something that's portable and easy to carry around with you. I always encourage patients to have a regular form of airway clearance that they use or at least one, sometimes two, so that they have something that they can always depend on and use as a tried and true form of doing their therapy when they're home. So some of the technology-free options that I want to talk about today include autogenic drainage, or AD, active cycle of breathing, which is ACBT, hand vibratory positive expiratory pressure, which hopefully is something you've never heard of, and huffing and coughing, because all of these are forms of airway clearance that you can do on the go. I want to start with autogenic drainage. This is a system of breathing exercises that was developed in 1967 by Jean Chevalier in Belgium. It uses controlled breathing to maximize the amount of air that you can blow out so that you can avoid wheezing and having the airways kind of shut down and trap mucus. So it's a very difficult technique to learn, but I'm going to walk you through it a little bit. The three phases include unsticking, which is where you start with very, very small lung volumes, and this is a way of getting mucus out of the most peripheral or the edges of your lungs into a place where it's easier to cough the mucus up. In the second phase, called collection, the mucus in the medium airways is kind of moved towards a central area where it can be coughed out by using larger lung volumes, but they're still very small, even smaller than you would normally do if you were just resting and relaxing. And then the evacuation phase is when you clear the mucus from the central airways by doing a larger lung volume so that you can get air behind the mucus and push it out by blowing out forcefully enough to move the mucus, but not so forcefully that you cause wheezing or airway closure. So as you can tell by looking at these instructions, it's not as simple as just kind of picking it up and starting. You really have to be trained. And a lot of respiratory therapists can train patients how to do this technique, but it takes a lot of practice to get good at it. So this is one of those things, if you're interested, you should go back to your respiratory therapist and find out if they know how to train or if they can recommend someplace where you can go to be trained. But just be aware that it does require a lot of practice, and you have to get good at it before it works well for you. Active cycle of breathing is a technique that's also been around for quite a long time. It incorporates breathing control, thoracic expansion exercises, and a forced expiratory technique. This circular diagram here kind of shows you how the technique works. You don't stop at any one point. You kind of go through the cycles of doing breathing control. And the breathing control is kind of a normal, gentle breathing with relaxation of the upper chest and shoulders, and it includes pauses for rest and also to prevent the wheezing or the airflow obstruction that causes people to trap mucus. So this is what the breathing control part of it looks like. The thoracic expansion exercises, you can imagine, it includes deep breathing, and you're trying to make sure that you have a nice big breath, but you aren't trying to do an uncomfortably big breath, and you're trying to keep as relaxed as you can. When you take that big breath, if you can manage it, it's really good to hold your breath, because then the air can kind of move around in the lungs and get behind all of the areas where there's mucus plugging. The next part of the airway clearance technique is the forced expiratory technique. And this, again, is kind of something that you can finesse and learn how to do, but essentially what you're going to be doing is taking a few little breaths and huffing with small lung volumes, then relaxing and doing some controlled breathing again, and then a few more huffs with bigger volumes, and then some more controlled breathing again, and then some huffs with very large volumes so that you can help to move the secretions along. And then hopefully when you come to the point where you cough, things are so far up in your airway that it's very easy and you don't have to force the cough. So that's the whole idea with this, is to work mucus out by using your breathing so that you don't have to forcefully cough. So with any of these techniques, you have to kind of continue to repeat the cycles and cough, usually for a minimum of 10 minutes, sometimes more. Sometimes you have to stop because it's exhausting. So you start with kind of doing a cycle, then resting, and you keep on repeating the cycles until you're not productive anymore or until you're too exhausted to continue. These breathing techniques can be assisted with gravity. So if you lay your body in a position where you are more likely to drain mucus, you might find that your technique is more effective, but you also have to be aware that there's a risk of reflux when you lay with your head lower than your hips. So you have to keep that in mind too. Hand vibratory positive expiratory pressure is a new technique that I learned about in 2010 at the CF conference in Florida, I think it was that year, and Michael Canting was the respiratory therapist that shared this technique. So I'm going to show you the photograph first, because this kind of shows what you do. You don't have to use any equipment, but what you do is you use your hand in the shape of a fist, and you hold your hand in front of your mouth as you exhale, and you can also squeeze your hand a number of times during your exhalation to kind of create an oscillation or a fluttering effect. And these are the instructions. So you hold your hand in the shape of a fist. You place your hand in front of your mouth with your thumb side close to your lips. Take a deep breath in through the mouth and hold that breath for a few seconds, if you're able to. Blow out forcefully and completely through your closed fist. As you exhale, you can adjust your fingers to make your fist tight or loose. This controls the amount of positive expiratory pressure, or PEP. And you can squeeze your hands as many times as you can physically do it during the exhalation. And you can keep repeating this method back and forth to remove more secretions. So here's that picture again. And at this point, I'm going to show you a video of this same young lady doing the technique, if I can figure this out. So she's taking in a big breath and holding her breath. She's going to move her fist to her mouth. She's exhaling through her fist, and at the same time she's squeezing her hand to slow the air down, and it immediately makes her cough. So that's how that technique works, and you could either try and do a few of them a few cycles and then try and cough, or you can do one cycle, cough, and then keep repeating it after you take time to rest. So huffing is something that a lot of people talk about, and I just want to kind of take a few minutes to describe to you how huffing actually works, because it's kind of a confusing method. Huffing is a low-pressure cough that you do without closing your glottis. So if you can imagine taking in a slow, deep breath, you concentrate on keeping your voice box open, keep your mouth open and shaped like an O, and then give a short exhalation similar to what you would do if you were fogging a mirror. Another way to do airway clearance that I think is very essential but also not really talked about much is exercise. All of us need exercise, and for CF patients it can be especially effective. The benefits include controlling weight, combating health conditions and diseases. I don't know if you're aware of it, but for a lot of people that have diabetes, simply exercising can help to reduce your blood sugar. It improves mental health and mood. It boosts your energy and your stamina. I think that can only help in CF. It definitely promotes better sleep. It strengthens and tones your body, and it enhances your flexibility. So some of the recommended activities, certainly anything is a good activity. Just keep moving is always helpful. But swimming, bicycling, horseback riding, walking, jogging, the treadmill or the elliptical trainer, or jump roping, any kind of activities that keep you moving and help to increase your heart rate a little bit are very beneficial. Horseback riding kind of has an extra added benefit because the bumping of riding a horse helps to jar your air loose from your lungs, and that kind of acts as a type of airway clearance also. So I wanted to show you some pictures of one of my heroes. This is Michelle Jones, and the thing I really admire about Michelle is that she never lets CF get in her way. She takes CF on the road with her. So she does her airway clearance and her therapies no matter where she's at. And I have a few pictures that kind of demonstrate that. She's very active. She's demonstrating all these activities that I recommended to you that are great for airway clearance. She swims, triathlons, runs, hikes, and then this is my favorite picture because this is taking CF on the road. She takes all of her equipment with her, and here she is sitting on a bed in a hotel room with her nebulizer and her vest, and she is doing her airway clearance and doesn't let the fact that she's traveling get in the way. I would like to thank Michael Canteen from Morristown Medical Center in New Jersey. He is the one who developed the hand PEP, and Michelle Jones, of course, was the September Hero of Hope in 2006. And I'm going to open it to questions now.
We have one from our online audience, Steve in New York City. And he asks, are there guidelines for airway clearance that are published? And if so, can you direct him to them?
The guidelines for airway control, airway clearance. There aren't actually guidelines. It's always a recommended form of therapy for patients with CF, and in general, the physician is who decides how often you do airway clearance. I would say for most patients, we recommend 2 times a day, every day. Some patients need to do more airway clearance than that, but it really is a physician-driven decision. The CF Foundation does have information on their website about the different types of airway clearance and maybe some recommendations, but probably doesn't recommend how often you do it.
So maybe just a description of what the different ones are. Thank you.
Anything else?
I have a question. When you describe breathing and you say take a deep breath, do you mean that breath to be in the upper chest area, the lower area? What do you usually mean? Aren't there 2 different ways we could go with that?
I'm glad you asked that, because one of the things that's important when you take that deep breath is that you use your diaphragm. So you want to feel your stomach kind of pointing out when you take a breath. Instead of your upper chest moving, you want your lower abdomen to be moving, because your diaphragm is your strongest breathing muscle. So you really want to take advantage of that when you're taking a deep breath, so that you're not using a lot of your muscles that get tired and sore easily.
Thank you.
I'd like to ask how healthcare providers prescribe equipment. Okay, we're talking about portable equipment, let's say the vest. What criteria do they use to prescribe? Because certainly every individual is different, with the need for a vest.
Well, I think that, again, depends kind of on the provider. As a respiratory therapist, one of the things that I like to do is work with families to find out what will actually work for them, what's going to work into their schedule, and what kind of devices will help them to achieve the therapy that they need to do. Having said that, physicians definitely have a preference often about what airway clearance they feel is the most effective. Although the studies show that everything is pretty comparable, sometimes a physician will decide that they like something better than the other. Like in our pediatric center, I would say that the vest is very popular because they feel that it's pretty foolproof and that the families can use it easily and benefit from it without a lot of trouble because they don't have to do it a certain way. In other words, it's pre-programmed to run in a certain method so that it does the therapy without the families having to think about it too much. So I have found that that is true for some families. They really do benefit from having something that's very easy for them to use, and that's dependable and always there. For other families, the expense is something that puts them off, and they need something that's more affordable. Chest physiotherapy doesn't really have a cost, so that's something that all families are taught to do, and it's a good backup if equipment does break down. So that's pretty much how the decisions are made. We try and give the patient some preference about what they would like to do or what they think would work for them or what they think works the best for them, and then we kind of go from there and we work together as a team to try and decide what will help. Anything else?
Is there an established order for airway clearance techniques, CPT, et cetera, pulmozyme, hypertonic saline, et cetera?
There is an established order, and I'm going to try and state it for you, but I may have to refer you to me via email because it's hard to remember the order. But essentially, you want to start by doing a bronchodilator like albuterol or Xopenex to open the airways up. And then the next medication you're going to use is going to be the hypertonic saline to help to thin the mucus and get it to flow easily. If you both use hypertonic saline and pulmozyme, then you would use your pulmozyme. And although there are a lot of theories about pulmozyme and hypertonic not working well together, there hasn't been any published proof that I've been able to find, even asking the people at Genentech. So pulmozyme can be given directly after the hypertonic. And then all the while you're going to be doing your airway clearance. At the very end of your airway clearance is when you're going to be doing antibiotics, if you're inhaling any antibiotics. And the very last thing that you're going to do is to breathe in any type of inhaled steroid that you would have, because you want that in there to work when everything else is gone, or when you've gotten out as much mucus as you can. I don't think I left anything out, but I may have. So don't quote me on that one. Thank you.
I've been recently started using the Minnesota protocol for the vest. Are you aware of that? And do you know what the thought is behind the different frequencies and sort of increasing and decreasing the frequency of the vest settings?
Well, the Minnesota protocol and the use of the vest and the different settings for the vest have been pretty widely studied. The vest probably has been studied more than a lot of other devices, and that may have something to do with the fact that it's a very expensive piece of equipment and there has to be a lot of research to get insurance companies to agree to it. The Minnesota protocol is what we recommend at our CF Center because it does give some good varied frequencies and pressures, and if you are interested in what that protocol is, I invite you to send me an email and I'd be happy to share it with you. Depending on the brand of vest that you have, some vests don't require that type of protocol. There are 3 competing vests that are available on the market, so it does also depend on the brand that you have. But the Minnesota protocol is what the Hill-Rom vest is set up well to do, and it also includes wearing a vest that fits a little bit higher up on the chest, so it has less room for the neck. That's kind of the major difference of the Minnesota style vest. Anything else?
For people who either have lung damage in one lung or perhaps have cracked or broken a rib, can you suggest, I'm imagining that to have the same percussion everywhere on the chest could be painful and maybe slow recovery, but I don't know.
It can be very painful, and often you have to make allowances when you have pain in one certain area. There's a lot of different techniques that you can do, like splinting, where you use a blanket or some sort of a pillow with your hands to hold that area still while you cough. There's a lot of techniques that help to splint that area, and generally the vest is not very comfortable when you're having chest problems or when you've had recent surgery. So that's why it's helpful to talk with your CF team about finding a different alternative for yourself while you're recovering from that. Thank you very much. Again, please send me any emails that of any questions that you think of. I'd be happy to answer them for you.
Kristen, could you give your email out at this time so that anybody who would like to follow up with you can reach you?
Sure. My email is kshelton@lpch, as in Lucille Packard Children's Hospital.org. Thank you.
We did get one more question if you want to
Yes, here you go.
If bronchial is approved next year, will it or should it replace hypertonic saline in the daily treatment regimen?
I think that when new medications are acknowledged by the FDA, there's a discussion that happens between all the CF care centers and the directors, and they are the ones that decide how we're going to use it, and then the recommendations come from there. So it's too soon to really say what the impact will be or if it'll be replacing anything.
Wonderful. Well, I'd like to thank Kristen very much. Let's tell her how grateful we are for you to bring your expertise and to take your time to give us this overview and a reminder for some of us of the choices we have and the idea of how important it is to work with your group, with your healthcare team. That's wonderful. So, round of applause for Kristen.
Thank you very much.
So just a few closing remarks. I want to give a special thanks once more to Genentech and to Gilead Sciences, who are each present in their own way. We do have Tim Cochran here with Gilead if you have any questions for him. Thanks to them for covering the costs of this Discovery Series today. Please complete the evaluation sheets before you leave, and we'll be back at the Crowne Plaza Cabana next month on Tuesday, March the 13th at 6 p.m. for our next presentation of the CF Discovery Series. Join us for a talk about allergic bronchopulmonary aspergillosis, or ABPA, with Dr. Rick Moss of Stanford University School of Medicine. Have a good evening. Thank you.